Here is the comprehensive, high-yield review without any fluff. 1. Pathophysiology, the vicious cycle. CKD is the irreversible, progressive loss of functional nephrons. The BCSE loves testing the mechanism of progression. Initial insult, an underlying cause, toxin, infection, congenital or idiopathic, destroys a significant number of nephrons. Compensation, the surviving nephrons undergo compensatory hypertrophy and increase their single nephron glomerular filtration rate, hyperfiltration, to maintain overall kidney function. Eventual failure. This hyperfiltration increases intraglomerular pressure, which damages the remaining nephrons, causing glomerulosclerosis and proteinuria. This creates a vicious cycle, where the kidneys continue to destroy themselves even after the initial insult is long gone. 2. Clinical presentation. Patients often compensate until the disease is advanced. Key signs the boards will describe include PU-PD. Often the first recognized sign. The kidneys lose their concentrating ability before azotemia develops. GI signs. Uremic toxins trigger the chemoreceptor trigger zone, CRTZ, causing vomiting, anorexia, and uremic stomatitis/oral ulcers. Neurological/muscular, cervical ventriflexion, classic in cats due to severe hypokalemia and lethargy. Ocular, sudden blindness from retinal detachment secondary to systemic hypertension. 3. High-yield diagnostics. The exam will require you to interpret lab work to stage and manage the disease. Urinalysis, the most critical early test. Look for isosthenuria, USG 1.008 to 1.012, in a dehydrated patient. This proves the kidneys cannot concentrate urine. Proteinuria may also be present. Chemistry panel. SDMA, symmetric dimethylarginine, the earliest biomarker. It elevates when 25 to 40% of kidney function is lost and is not affected by muscle mass. Azotemia, elevated BUN and creatinine. This does not occur until 75% of functional nephrons are gone. Electrolytes, hyperphosphatemia, due to decreased GFR, hypokalemia, especially in cats, and metabolic acidosis, CBC, non-regenerative, normocytic, normochromic anemia, due to a lack of erythropoietin production by the renal cortex. Imaging, radiographs or ultrasound typically show small, irregular kidneys with poor corticomedullary detail. Exception for the boards, polycystic kidney disease, PKD, or renal lymphoma will present with enlarged kidneys. 4. Iris staging. The International Renal Interest Society, IRS, staging, is heavily tested. Staging must be done on a well-hydrated, stable patient using fasting blood creatinine, or SDMA. Stage 1, non-azotemic. Creatinine less than 1.4 mg per deciliter, dogs, or less than 1.6 mg per deciliter, cats. SDMA less than 18. Some other renal abnormality is present, e.g., persistent proteinuria, abnormal imaging. Stage 2, mild renal azotemia. Creatinine 1.4 to 2.8 mg per deciliter, dogs, or 1.6 to 2.8 mg per deciliter, cats. SDMA 18 to 35. Clinical signs are usually mild or absent. Stage 3, moderate renal azotemia. Creatinine 2.9 to 5.0 mg per deciliter. SDMA 36 to 54. Systemic signs, vomiting, weight loss, become obvious. Stage 4, severe renal azotemia. Creatinine greater than 5.0 mg per deciliter. SDMA greater than 54. High risk of uremic crises. Substaging is required for every stage using two specific parameters. 1. Proteinuria, measured via urine protein creatinine, UPC ratio, categorized as non-proteinuric, borderline, or proteinuric. 2. Blood pressure, categorized from normotensive, less than 150 millimeters of mercury, up to severely hypertensive, is greater than or equal to 180 millimeters of mercury. 5. Medical management. Treatment is tailored to the IRIS stage and substage to slow progression and improve quality of life. Dietary therapy, the most proven intervention for extending life. Renal diets are restricted in phosphorus, restricted in high-quality protein to reduce nitrogenous waste/uremia, and supplemented with omega-3s and antioxidants. Phosphorus control. If dietary restriction isn't enough to normalize phosphorus, use enteric phosphate binders, like aluminum hydroxide. Exam tip. These must be given with meals to bind dietary phosphorus in the gut. Hypertension management. Amlodipine, a calcium channel blocker, is the drug of choice for severe hypertension in cats. Proteinuria management. ACE inhibitors, enalapril, benazepril, or angiotensin receptor blockers, telmisartan, are used to reduce glomerular pressure and protein loss. Hypokalemia, oral potassium gluconate supplementation. Anemia. Erythropoiesis-stimulating agents, like darbepoetin, are indicated if the PCV drops significantly, typically less than 20%, and is causing clinical signs. Uremic GI signs, antiemetics, meropitant, ondansetron, and sometimes gastric protectants/antacids, omeprazole, if GI ulceration is suspected.